Typically, carotid disease is not painful. It is presenting symptoms typically, unfortunately, is a stroke, either from not having enough blood flow to the brain or a piece of clot or thrombus forming and then shooting upstream, causing a stroke. My name is Hakma. I'm a dual-trained neurosurgeon. I specialize in the blood vessels that provide the blood supply to the brain. We deal both with the vasculature in the neck as well as the vasculature in the brain. So I'm a cerebrovascular neurosurgeon. So carotid disease is a pathology that involves stenosis or blockage in the carotid artery. Typically, it's around the bifurcation. We have a common carotid artery, and then that bifurcate into the internal carotid artery and external carotid artery. Most of the lesions is atherosclerotic in nature and happens to be around the bifurcation. And as we get older, there are some risk factors that make patients more prone to have carotid disease. And over time, this stenosis or the blockage can increase in severity to the point it becomes symptomatic or can cause stroke in the brain. Carotid disease is a part of the atherosclerotic disease that we get as we get older. So all of us will have some degree of atherosclerotic disease as we age. It can be accelerated by certain factors, family history, high cholesterol, smoking is a big one. We tend to find that smokers have a very high risk of having carotid disease. Other risk factors such as hypertension, diabetes, renal disease, dialysis patients tend to have carotid stenosis. So there's certain risk factors that will make the process go faster and more profound. So the three ways that we diagnose carotid disease is carotid ultrasound, CT angiogram or MRI angiogram, and catheteroangiography. Obviously, the carotid ultrasound is the least invasive. However, it's not very specific. Quite often we have patients who had high degrees of carotid stenosis on the ultrasound or the CT angiogram, and then we do a catheteroangiography and it doesn't show such a high degrees of stenosis. Quite often we do a diagnostic angiogram thinking we're going to proceed with angioplasty and stenting, and we do the angiogram and the stenosis is not even 50%. So the ultrasound and maybe the MRA or CT angiogram is a good way of surveillance, but quite often we do a diagnostic angiogram to confirm the degree of the stenosis, especially if it's on the cusp or marginal. Let's say if it's 50%, 60% on the ultrasound MRA, then maybe a diagnostic angiogram is warranted. If it looks like it's really bad, meaning that it's 90% on the CT angiogram and the patient is going to undergo a carotid endarterectomy, at that point probably it's not worthwhile to have a catheteroangiography. So we tend to tailor the treatment paradigm for the patient, what we find on the non-invasive studies, the degree of the stenosis, and if the patient is having angioplasty and stenting, then obviously we're going to do angiogram. If they're going to do a carotid endarterectomy and the degree of the stenosis is very profound on the non-invasive study, then probably we'll skip the angiogram and just go ahead to surgery. Typically, carotid disease is not painful. It is presenting symptoms typically, unfortunately, is a stroke, either from not having enough blood flow to the brain or a piece of clot or thrombus forming and then shooting upstream, causing a stroke. Sometimes it's found incidentally by screening or when it becomes symptomatic, and pretty much the only symptoms at that time will be giving the patient a stroke or a focal deficit, where the patient having slurred speech, weakness, numbness. Occasionally can present with vision loss. If the clot or the thrombus move to the artery of the eye, it can present with a vision loss. To prevent carotid disease from progressing, quitting smoking is essential. That's the biggest thing that we can do to modify the patient risk factor is smoking cessation, blood pressure control, diabetes control. So we try to modify the risk factors that we can. And these are usually the biggest three things is diabetes, blood pressure control, and smoking cessation. Another risk factor for carotid disease that we can modify is hyperlipidemia. So if a patient have a carotid disease or any type of atherosclerotic process, having very tight control of their lipid profile is essential. The newer medication of the statin is very effective at lowering a patient's cholesterol level, and that will help stabilize the plaque, stabilize the degree of the stenosis, and sometimes can reverse it and make the stenosis becomes less profound. So one key factor when deciding if we're going to treat carotid disease or not is to decide if the patient is symptomatic or not symptomatic from the carotid disease. That's a key factor in the decision making. For symptomatic carotid disease, anything above 50% and cause the problem, meaning the patient had a stroke or a TIA that's attributable to the ipsilateral carotid disease, that's an indication for treatment. So for symptomatic carotid disease, it's rather straightforward and it's pretty much standard of care. For asymptomatic carotid disease, that's where it gets a little bit confusing sometimes. When you get referred a patient who has 60%, 70% stenosis, and they found on screening study for some reason, the guidelines now is that we treat anything above 70% for asymptomatic carotid disease, as long as the patient comorbidities and you're able to do the procedure with a complication rate of less than 3%, then it's beneficial. Now, there's new studies ongoing still called the CREST-2 trial, and that is looking particularly at the benefit of surgery or intervention on asymptomatic carotid disease, and the outcome of the study it's still in progress, and that might change our management in the future. But as of now, 50% or more for symptomatic we treat, 70% or more for asymptomatic we treat. Patients between 50 and 70%, if they're asymptomatic, we tend to monitor them with serial carotid ultrasound every 6 months or once a year. So TCAR is a newer procedure that we've been using for revascularizing the carotid artery. And the benefit of it is there's a reversal flow. So basically what we do is we do a cut down on the common carotid artery and put a catheter in the carotid artery and have an access in the femoral vein and have the flow go reversal from the brain into the femoral vein. This way, when we do the angioplasty and stenting, if something breaks loose, it doesn't shoot to the brain. It actually reverses and get captured in a filter while the blood is being transferred to the femoral vein. So that's the beauty of the TCAR procedure. Other procedures that we do, angioplasty and stenting has a different mechanism of protection. There's a distal protection device that we use for angioplasty and stenting, and that can capture some of the debris or the thrombus that can form or break loose from the angioplasty and stenting procedure. So restenosis after a carotid artery surgery, either with endarterectomy or angioplasty and stenting, can occur, but it's not a common occurrence. Maybe two or three times a year we have to retreat somebody who has been treated in the past for angioplasty and stenting or carotid endarterectomy, but it's rather rare than a common finding. Both procedures, they're very durable in their nature in terms of the outcome, the revascularization of the carotid, and the outcome is very good for both procedures. However, restenosis can happen, and that can be readdressed with typically endovascular approach. So the type of recovery from a procedure depends on the procedure that we're doing. For example, if we're doing a transfemoral angioplasty and stenting, the patient comes in the morning, they go to the hybrid room, and they have a femoral artery access, so have a needle stick in the groin. The patient's usually under general anesthesia, so they're asleep, they don't feel any pain. They have the procedure done, they spend the day in the ICU, and they're home the next morning. So the recovery from transfemoral angioplasty and stenting is rather quick. The restriction over the next couple of days will be just avoid heavy lifting, make sure they're taking their medication, particularly the dual antiplatelet regimen, which is essential after placing a stent. So the recovery from a stenting procedure is rather quick. Carotid endarterectomy, it may take a little longer to recover from just because the nature of an open surgery. You'll have a cut in the neck. about maybe 4 or 5 inches. You'll be sore after the surgery at the surgical site. You may have some difficulty swallowing. You might spend an extra day or two in the hospital recovering while the drain comes out, pain control and all that. And most people need about 4 to 6 weeks to recover from a carotid endarterectomy. Relationship between the atherosclerotic disease in the heart and the brain, it's usually part of the whole picture. Some patients are more prone to carotid disease versus intracranial atherosclerotic. Genetics can play a factor. For example, carotid disease is more prevalent in Caucasian. Intracranial atherosclerosis is more prevalent in African American or Asian. So there's some genetic component to it. And once the patient is diagnosed with coronary disease, we start to look for carotid disease and intracranial atherosclerosis, and that's why you see a lot of patients being referred to us from their primary care cardiologist because they were diagnosed with coronary artery stenosis or disease, and they did surveillance with a carotid ultrasound and found carotid disease. So it's a part of the overall process that contribute to the atherosclerotic process in the whole vasculature. By our training, we're dual-trained vascular neurosurgeons, so we're comfortable doing all 3 types of procedure if needed. So we're able to provide our patients with a paradigm of management, beginning from the screening to the decision if we need to treat or not treat. If we're not treating, we can provide the patient with the continued surveillance, maximum medical treatment. If we decide to treat the patient, we're able to provide them all 3 options: the angioplasty, or what's called a transfemoral angioplasty and stenting, TCAR, or transcarotid angioplasty and stenting, or open surgery. And we tailor the treatment paradigm based on the patient pathology, age, risk factors, the morphology. It's not one procedure that we try to enforce on a patient just because that's what we do. We're able to provide all type of treatment for the patient.